All right, we are live. Let's get rid of this. And we should be good.
Okay. Great. Good morning, everyone, and welcome to Grand Rounds. It's my pleasure to welcome our speaker today, Dr. Ken Margulies from University of Pennsylvania. Dr. Margulies is a professor of medicine and physiology at UPenn. He received his undergrad at Princeton and his medical training at Jefferson Medical College. He did specialty training in internal medicine and cardiovascular diseases at the Mayo Clinic and is board certified in these specialties as well as advanced heart failure and transplant cardiology. Since 1993, Dr. Margulies has been an active physician scientist in Philadelphia, first at Temple, and then from 2004 to the present at UPenn. He serves as Director of Heart Failure and Transplant Research and Director of Cardiology Clinical Research at Penn. He receives funding from the NIH and several commercial entities developing new therapeutics and diagnostics for heart failure. We were talking last night, was one of his major contributions was first demonstrating the benefit of combined neprilysin and angiotensin inhibition for heart failure. In his many contributions, he's elucidated cell biology of myocardial recovery, helping define integrative molecular architecture of failing human hearts, and establishing the central role of human heart tissue characterizations as a foundation for heart failure translational research. His current research focuses on load-induced myocardial remodeling, mechanisms of myocardial failure, recovery, and metabolism, and many other topics. I'm astounded by the diversity of your work. His research inquiries employ human heart tissues, iPSC-derived human cardiac myocytes, engineered myocardial models, animal models, and proof of concept clinical trials. I met Dr. Margulies recently when I visited UPenn and was so excited by his recent studies into new diagnostic approaches for cardiac allograft vasculopathy, something I'm very passionate about. And I'm so happy to welcome him here to Yale today to share his work with us. Thank you and welcome.
Thank you. Hey, True. Yep. Hey, thank you for the kind introduction. Appreciate it. Happy to be here and see some old friends and new. This is the first time I put this together as a roadshow, maybe a little rough around the edges, but I think there's a critical mass of work to present that I think you'll find interesting. I hope you will.
That's my fault. My apologies. There you go.
Okay, great. Okay, so as shown here, there is some IP related to this work. That's my only disclosure. There's no conflicts. The work is funded by the NIH. The outline of how I'm going to go about this today, I want to do a little bit of a general background on machine learning and artificial intelligence methods because they're critical to what I'll be presenting for the bulk of the talk. And then get into something that we've labeled at home computer-assisted cardiac histologic evaluation. So it's our particular nomenclature for what we're doing, right? We're taking histology slides of one sort or another and looking at them with a different lens, basically the benefits of artificial intelligence and machine learning. And I'll go into that a little bit. And then three applications that we've been able to deploy in a relatively short period of time for reasons that I'll highlight of why it's efficient to do work in this area, which I like. One related to rejection grading, one improved rejection phenotyping from a mechanistic point of view, and early detection of allograft vasculopathy where Kathleen and I have some common interest. This is not my usual habit to put the acknowledgements up front, but I am in this case because I've leaned heavily on these two individuals in this whole body of work. So I want to highlight them at both the beginning and the end. Elliot Peister is currently a faculty colleague of mine, but I knew him since he was an internal medicine resident, and he and I began working together during those years about 8 years ago and have continued. And as you see from the bottom part, the three first author papers that form the basis of this are all driven by him. And Anand Matabushi is a computational expert biologist who did his PhD at Penn in bioengineering, and it's gone on to have lots of applications of machine learning for image analysis, mainly in cancer. And so we kind of pulled him into a cardiovascular application. And of course, his know-how has been extremely beneficial and taught us a lot. So these two deserve all the credit. So let me begin with a little bit of overview about computer image analysis. I'm not going to go into great technical depth here, but I want to give a high level summary. So the idea of, and again, people hear the term machine learning. What does it mean exactly? It describes computational models which autonomously learn through experience. And that learning and getting better over time is a key feature, but they do need some training up front, at least one type that I'll get into. An established role in analyzing big data sources. We've heard about how companies use this for commercial purposes, about consumer preferences and things like that, and also how in medicine we use it to look at omics data or electronic health record data, and use language processing and other techniques that have become fairly well evolved at this point. There's also an emerging role in looking at what we might consider unconventional data, whether it's spectra or sounds or images. And of course, I'm going to emphasize images in this case because we're looking at histologic sections. And so this specific area of computer image analysis describes the use of machine learning to perform automated mathematical extraction, computational extraction of analysis of pixel data. And I'll show an example of how that happens. Oops, go back. So first I want to, before talking about the interface between transplant medicine and machine learning and computational image analysis, I want to give a little background about heart transplantation, and again, at a high level. We're always balancing competing risks in transplant medicine, maybe in all of medicine, but especially in this area, right? And the two that come up the most frequently in transplant cardiology are this balancing of the concerns about cardiac allograft rejection and concerns about the consequences of immunosuppression, the adverse consequences, right? So the immunosuppression is how we prevent the rejection, and every patient needs to be on immunosuppression. And yet we have, dark side of immunosuppression to worry about. And so the rejection is still in the modern era, happens at 20% in the first year. It's not always symptomatic or severe, but it still can be severe and symptomatic. Immunosuppression has both early and late consequences. Early things like infection, later on like cancer or some of the other consequences of renal dysfunction, et cetera. And again, it ends up over time being a more leading cause of death after the first year than the rejection. And yet we can't get by with no immunosuppression in this field. And then how do we manage this? Well, the current state of the art still, although it's evolving, and I'll talk a little bit about that evolution, is we use invasive tissue sampling. So that back in more than 30 years ago, Margaret Billingham at Stanford sort of perfected the endomyocardial biopsy technique with a specially designed bioptome that we still more or less use. And it's the established method for surveillance that we use. For decades, heart transplant recipients have undergone 10 or more scheduled surveillance biopsies, whether symptomatic or not, in the first 1 to 2 years post-transplant, often more than just 10. There's lots of archived tissue as a result of that. And this is circling back to what I said earlier, this notion that we have an opportunity to work very efficiently here, because the habit of pathology labs is to save everything that comes out of human beings and to save it in paraffin. And lots of these biopsies have not been exhausted. In fact, so although we get a clinical read the next day, we still have lots of archived tissue. And this enables, especially combined with the EHR, a tremendous potential for retrospective cohort studies, right? So forward-looking studies that were all done in the past, but we get to see the outcomes. And you'll see in the rest of this talk that will exploit that design feature quite a lot. And so we get these histologic sections, and we can make new sections from old slides, or dust off previously sectioned slides and scan them in. I want to go a little bit again as part of the rejection, just to talk about our rejection grading scheme that we've been using in one. There've been updates to it, but it has the same features and the same pitfalls for the whole past 30 years that we have established histologic criteria. It's a qualitative histologic grading of H&E stained slides, even though we could do much better. It's based on the presence of inflammatory infiltrates, little blue cells, as you see in the upper right-hand side of this. It's a rough estimate infiltrate extent, right? It's not a quantitative thing, and it gives signs of vaguely defined myocyte damage, which earns you a lot of points when we're doing the grading scheme. And as shown in the bottom right, the updated scheme is already, pretty old, and 2004, and so it's based on these features and how much they're present, whether it's multifocal or single foci, and whether there's diffuse or focused infiltration of cells, and how many of the biopsy pieces show this. Okay, so it's a little more subtlety than that table makes it, a little more subtle than that table makes it seem, right? That you can have these 3 grades as shown here that, from the low power view doesn't look that different, right? And yet they were graded by pathologists at 1R, 2R, and 3R, right? Mild, moderate, and severe. And again, this is supposed to be based on the differences in the number and the extent and the distribution of the inflammatory infiltrates and how much myocyte invasion. But suffice to say, it's a subjective qualitative assessment done by human beings, and there are concerns. In fact, the concerns are really well known, and not, I'm not the first person to highlight them, that the reliability is not very good. Pathologists in general, historically, have agreed about 70% of the time across the range of biopsies about what grade it is of those. And it's only 4 grades, right? 0, 1, 2, 3. 70% agreement on 4 grades. If you cull out the stone cold normal ones, the agreement's in the 40% range. And we make big decisions, right? A 1R typically does not get treated, and a 2R or 3R does get treated. 3R gets treated heavily. And so these distinctions across this 4 grade, we make big decisions about how much immunosuppression people are getting based on these grades, and yet it's notoriously unreliable. So there's also a limited accuracy, right? The correlation with people's clinical syndrome is really very imperfect. Now, that's often been excused by the say, of course, we're trying to pick it up early. We're trying to pick it up in its asymptomatic phase. So we have to be a little bit biased towards asymptomatic pickup of rejection, and that's justifiable. But it also, it's not that hard to understand how that might, in the composite, result in overtreatment, excessive immunosuppression, and maybe shifting that balance more towards infection and malignancy risk, and renal failure risk, and less towards protection against rejection. And to date, none of our techniques have had prognostic value. So the biopsy we take this week has never been felt to teach us anything about the patient's future in 3 months, 6 months, or a year from now. It's just not the way it's been envisioned, but we actually think there might be subtler signals in there that could teach us more along those lines. So the theme for the rest of this is we think we can do better with modern techniques applied to this old problem. So now we'll circle back to the digital approach. Histopathology is traditionally dominated by direct manual human analysis, as is the case with our endomyocardial biopsy (EMB) assessments. Over the past decade, digital archiving of histology slides has become common. So these same things that were in paraffin blocks or made into slides have been put through slide scanners at very high resolution. So we get really nice digital data on them. And that these are their data. These slides are data that can be mined, and the matrix can be interrogated with the right software. And so, simple figure 8 on the bottom there, when it toggles back between different numbers representing the intensity, and you can get the distribution. And so in the long run, you can turn something like this into something like this. And what's on the right there is a series of nodes and vectors and intensities that can be mathematically represented or pictorially, but then subject to computational analysis. So we're taking pictures and turning them into numbers that are suitable for computational analysis if you know how to turn them into features. And so I want to then talk about the advantages and the disadvantages of these methods, right? They're highly reliable, right? If you take the same algorithm and give it the same picture, it'll give you the same answer time and time again. And that won't happen with human beings, unfortunately. That it's easily disseminated, right? So if you wanted to have a digital pathology core lab, and you just wanted to send them via the internet to different centers across the globe, that's no problem here. It would be a bigger problem sending histology slides around the globe. And that's just one example of easily disseminated. It's modular, it's easily integrated with other, because it's computational and digital, and our omics data and other clinical data can be represented in digital formats. It's integrated with those other things fairly easily. It's high throughput, it's fast, it's low cost, and it allows, as I think I'll try to convince you of it, opportunities for discovery of novel biology. I think that's where we're at the frontier of not just doing things faster or more consistently. Now, there's a philosophy. So one of the takeaway points that I really want people to come away with is that you'll hear about machine learning and computational image analysis or other artificial intelligence techniques. And there's, of course, many, many different approaches, but there's two big broad ones that I want people to come away understanding. One is this idea of the one that's reflected on the right here called deep learning. It often uses techniques called convolutional neural networks or neural networks. It's nearly always the best performing at prediction. It's fast, it's the most unbiased, but it's highly opaque. It can't tell you how it did what it did when it predicted things. And that might be a concern for clinicians implementing the results of some convolutional neural network that was a few percentage points better in its predictive accuracy, but it can't tell you why. And especially if you're trying to inform biology and it couldn't tell you what were the features that it noticed, that's potentially a concern. On the other hand, there's a more laborious approach called handcrafted feature engineering. It goes by other names too, but that's the one I'm going to use. That is more laborious. You have to use your imagination, see features. Oh, I like the way the blue cells are clustered, or oh, let's think of ways to describe the extracellular matrix between the cells, or which part of the tissue it's in, and et cetera. That once you start defining these as specified features, you can generate dozens of them pretty quickly. But in the beginning, you have to define them, and then you have to train the algorithm to identify them reliably. But when you do, you end up often getting something that at the end of the process, once it's given you some predictive value, it can tell you which were the money features that really made a difference in the predictive value and which ones were redundant or didn't add any value. And that's really valuable, both in stripping down your models and telling clinicians or whoever is interested in looking at the answers, what missing features are teaching us something about the biology underneath that and which ones are not. Whereas with the deep learning, you can't get that. So I spent a certain amount of time here because I want, this is a general lesson about AI that people should know about. Okay, so this computer-assisted cardiac histologic evaluation, CACHE grader. So this is our first application. We want to introduce computer image analysis to transplant medicine and do it in a way that might be transparent and interpretable on the back end. And we wanted to test the following two hypotheses. First, that it can perform accurate, generalizable, and robust assessments of ISHLT grades. And two, that the CACHE grader is non-inferior to expert pathologists in terms of integrator agreement. Now, I've already planted a seed about a problem we're going to have here. And that is, we're going to do a non-inferiority assessment to something that's pretty inferior in the first place. And this is a problem in this field, right? When your reference standard is not a gold standard, it's a concern and it creates problems in assessing new diagnostics. I'll get back to that. So I'm not going to spend a lot of time on the technical aspects of how this is done, but I want to spend a little bit of time on it. This slide, the right side, illustrates sort of the high level view of the sequence to which these algorithms sort of attack a histologic H&E section. So the first part is it's not difficult to train it to segment just like human beings can do, can learn to identify which are the nuclei that are in myocytes, which are the myocytes themselves, which are non-myocytes between the cardiac myocytes, which are vessels, which are cells that are around vessels and things like that. These are not hard things for us to recognize when we look at a histologic section. It's not hard to train the computer to do that. So you segment into specific cell types to the extent you can do so reliably, and the nuclei associated with them. You identify lymphocyte clusters because they're important for this particular application. You identify lymphocyte foci that when they're beyond the small cluster in bigger areas of infiltrate that you might consider to represent rejection. And then because we have certain problems, something we call the Quilty effect in transplant medicine, where there are these subendocardial infiltrates that are felt to be more benign compared to the more in the depth of the myocardial infiltrates, which are not benign, we have to not only know what an infiltrate looks like and how it's shaped and what its extent is and its density, but we kind of want to know which part of the tissue is it in, because it makes a difference in our grading scheme. And so that's one of the particulars of this. And that's none of those things are that hard to do. And so then we moved on to a study cohort. And again, because I mentioned that transplant centers have lots of these, we could do a retrospective cohort and design and have almost 2,500 H&E stained histologic slides obtained from 3 centers: UPenn, Ohio State, and University Hospitals in Cleveland, and get decent numbers of cases with representing the different ones. Now we had to enrich a little bit for the more severe because they're less common, but if we have it too unbalanced, we're not going to have enough for statistical power. So we asked our centers, including our own, to try to find almost all the 2Rs and 3Rs they could, and then fill in the rest with more bland biopsies. And then slides were stained, digitized according to local center workflows and slide scanners. So that it's not done all on the same standardized machine, because that's not the real world. People are going to buy from different vendors, have different machines, and if you can't handle that, it's not going to be very applicable in the long run. I'm not going to go too much into this consort diagram, but I want to make a couple points. Again, there's 2 parts we wanted to do here. One is there's got to be image QC, like you've heard before, garbage in, garbage out. So but I want to point out that, let's say at Penn, where we did the training, the total number of these 2 adding up only misses about 30 cases from the total. So the QC fail rate is low. At Penn, it was about 3%, and in these other 2 sites, it was about 7%. So most stuff we have on the shelves in the pathology lab are adequate quality to do this. And what we don't want to have is things with big divots out of the middle of them, or they exhausted the block and they couldn't get a good sample. So we had a training set. We then subjected to both internal and external validation. And the key things highlighted in blue at the bottom here is we wanted to see what degree of agreement do we have with expert pathologists. And then we also, because we're aware of interpathologist disagreement at times, we wanted to do a regrading subset where we had the same 166 samples graded by 3 separate pathologists at the 3 different institutions and by the algorithm. So we have lots of comparisons even in 166 cases. So again, I realize this is busy. I'm just going to highlight a few parts of it. These are things from the paper. The first is, so I said it's only 4 grades, right? 0, 1R, 2R, 3R. But you can even make it simpler, because I also said that 0 and 1R we generally don't treat, and 2R and 3R we generally do. So you could say the real important distinction to make is between 0 and 1R combined and 2R and 3R combined. And then we can take it from there. And so we did both. So that when we're talking about this low versus high grade classification here, we're talking about just a binary. Is it 0, 1R, or is it a higher grade? And what we found is that our agreement with the grade of record at the site where the biopsy was done was pretty high. And the algorithm only needed 2 features out of, we trained it on a couple hundred features that it could look for in a biopsy, but only 2 of them were enough to do a good high versus low grade agreement with the pathologist of record. And you may say, well, what's so great about 85%? We'll get back to that. And then when we do the 4 grade one, the agreement is 66 and 65, 66 and 6, right? And so again, pretty good, especially since, the pathologists only agree with each other about that much. And so across the range, it was pretty consistent. It wasn't like it was really great at the zeros, but it really couldn't do the others. It was pretty consistent along. So agreement was 86% for high versus low, and about 66% for the 4-grade classification. So it was generally generalizable and robust, and as good as a pathologist in this non-inferiority analysis. This is the interesting part, right? We get to the regrading substrate, right? And so we have real live pathologists who are the leading pathologists at each of the institutions, Penn, Ohio State, and University Hospitals in Cleveland. And we look across the zeros, and there's some concerning decreases even in zeros and in grade 1R and grade 2R. The consistency is not high, which is what I foreshadowed earlier on. And the combined consistency is not good at all, especially in the higher grades, whereas this is where the design of the algorithm was to be, if anything, more consistent and more sensitive to detect high-grade rejection, because you can make those choices when you're designing an algorithm. And so in general, that higher subset of cases, the algorithm performed better than the pathologists. Again, we see that for the common 2R rejections, which are the ones that's usually our threshold for treatment, our consistency and agreement was much greater than the lower ones. And so the non-inferiority evaluation was a clear win, that the cash grader easily met the 5% delta for non-inferiority. There was 62.6% agreement among pathologists with the grader, and 61% agreement. With 62 and change with the algorithm agreeing with the pathologist, and 60.8 with the pathologists agreeing with one another. So certainly it was not inferior, but it's concerning that those are the rates. But this is what I told you is about the nature of the field. So I want to take a step back and first make a couple of take-home points, right? The digital pathology workflow clearly can reproduce a clinical quality grading and can standardize grading across centers, right? That's what's nice about this, is that although there's disagreement among them, the consistency of looking at the same tissue and getting the same answer is much greater here, of course. So to summarize this part, and then to get into the challenge of a weak reference standard, right? The quantitative morphologic features derived from a digital transplant biopsy slides are predictive of their corresponding rejection grades. The cash grader is non-inferior to the field's diagnostic standards, with the caveat that the diagnostic standard has some concerns. And that relatively parsimonious models with relatively few features. So even though we train the algorithm on dozens or even hundreds of features, when you look at which ones added value independently, it's relatively few. For the 4-grade, it was 7 or 8, and for the 2-grade, it was just 2. And that very imperfect reference standard will continue to constrain the development of newer potential superior approaches. We're already seeing that here, and I want to spend a little more time thinking about that. So this is not unknown, right? Medical people have been developing diagnostic tests for a long time, and this idea of an existing standard being inferior to where you'd like it to be and far from a gold standard is not a rare problem. But I did a little bit of reading into how people talk about how to deal with this, right? So reference standard bias arises when a reference test does not mirror the truth to the extent we can define it adequately well. And the worse the deviation of the reference test from the truth, the poorer the estimate of the new tests, the index tests, performance will be, right? Because it's being compared to something that itself is weak and unreliable. And when a reference standard, like a pathologist's interpretation, is frequently incorrect, which is what we have here, then a new test sensitivity and specificity can be markedly over or underestimated. It's just hard to know when you don't have, a gold standard, right? Or you have a weak standard. And so there's different options of dealing with this situation. One is what we did here, right? Where you just talk about how much they agree or disagree and decide whether there's inferiority or non-inferiority, as we did here. And so one approach to this is what we did here, is we just didn't talk about sensitivity or specificity too much per se. We just let the comparison speak for itself. And we did that. Another is that you start looking at outcomes from these cases, which you can do in retrospective cohort studies, and see whether which of the tests, or whether your new index test does better at predicting outcomes rather than just predicting the previous standard in the field. And treat the index test as a predictive instrument. And so again, this is 2012 paper from actually it was from, I think, what's it? The Institute for GCRI, which is the General Medicine Institute, generally, of the NIH. Okay, so let's move beyond grades then, and that'll give us an opportunity. So we're using computational image analysis to do more than imitate a pathologist. So the idea here, we're parroting a pathologist, but maybe that's not what we should do. Maybe we should be aiming to do something very different instead of having a digital parrot. We want to have new conceptual frameworks, maybe some grade agnostic assessments of rejection. We might want to do new disease applications, which I'll get to at the end, as coronary allograft vasculopathy, and maybe not just have it, maybe integrate different sources of data, because we might get more power out of that. And I'll illustrate all three of those. So one of the rationales for spatial immune profiling is that, first of all, the differences can be subtle, as I mentioned earlier, between different infiltrates that qualify for different grades. But in addition, sometimes things that are low grade or high grade, in addition to looking different, if on the right here, you can have people with clinically silent rejection. We see this all the time, right? People who, wow, it came back at 2R. I never thought Mrs. Jones was going to be rejecting now because she looks so good. And then you'll have somebody else who, wow, they're so sick, and you get a negative biopsy. And maybe that's always vexed us. And some of it is not because the pathologist graded wrong. It's because when we go to the pathology lab, we look at what they did, we said, I would have said the same thing. It's just not lining up with my clinical impression of this patient at this time. And we run into that not rarely also. And so we recognize that since Margaret Billingham developed this whole rubric and the ISHLT, that there's more to infiltrates than just the little blue dots, that there's a qualitative distinctions among those little blue dots. And we, with a little bit of immunostaining, can distinguish things that are pro-inflammatory or anti-inflammatory markers, or markers that can go either way. And so Elliot Beister designed a panel to try to get a little more texture to these blue dot infiltrates, and specifically identify, pan T cell markers, cytotoxic T cells, macrophages, regulatory T cells, and checkpoint system ligands, which we know are important immune modulators. And most important, several of these are anti-inflammatory. So not every blue dot is causing trouble. Some of those blue dots are actually anti-inflammatory and lessening injury. And to test the following hypotheses. One is, can we identify these immunophenotypes in our rejection, endomyocardial biopsies from transplant patients that seem to show rejection? And will it help resolve cases of clinical histologic discordance, which is what I was highlighting? And number two is, can we identify differences in immune phenotypes between patients at high and low risk for future rejection? Because maybe having a lot of anti-inflammatory cells in your infiltrates is someone who won't just be in better shape then, but maybe that's a good feature that'll help them do better moving forward. So again, it has its own workflow. I'm not going to go into too much detail, but the biggest difference is that it adds different color channels to this that identify the different immunomarkers, and this is not hard to get done nowadays. There are some systems that even with 1 day turnaround, you can get up to 90 or 100 targets with quick turnaround with some of the vendors, and others are competing to catch up and to do even better. So the idea of getting multiplexed immunophenotyping of many different markers that could distinguish subtypes is technically feasible. And the idea is, again, to turn this into digital data, and I'm not going to go into the details there. And again, the flow diagram, as you can see, this is a much smaller study, right? We've since tripled this. Still not as big as what I had with the H&E and all the things. Again, these are somewhat expensive right now to do these studies, but getting cheaper. But we had successful staining in 34 biopsy slides. They were divided into low grade and high grade based on the pathologist grading at original time of acquisition. And then we subdivided each of those two, low grade and high grade, into clinically evident and clinically silent. And again, the numbers are not big, but this is a proof of concept study. And then among the clinically silent ones where everything agreed, right? So clinically silent, concordant, low, which means the ISHLT grade was low and it was clinically silent. We then looked going forward, right? Because these are all retrospective cohorts. I said, did these people ever reject or did they never reject? And that might be of interest to look at. So let's look at the results. This is a lot of data here. I'll take a little time going over it. So there's hidden information that the grade misses, right? And that when we look at the CD3 and CD8, which are generally things that are pro-inflammatory that we would expect to line up with the ISHLT grade, that more cells means more inflammation, means more likelihood of rejection. We see that for the most part, the high histologic grades had high levels of these two markers, and the low histologic grades had lower levels, and the clinically silent versus clinically evident didn't make much difference for those. So they were not driving or associated with that distinction between clinically silent and clinically evident. When we look at some of these that are known to be involved in some anti-inflammatory, some immunomarkers are known to be anti-inflammatory, then we get a different story. We see that they're sorting much better between this distinction between clinically silent and clinically evident in whether the histologic grade is high or low. And so when you have lots of higher volume of PD-L1 or FOXP3, you're likely to have a clinically silent infiltrate, irrespective of what the ISHLT grade was by the pathologist or our algorithm. And on the other hand, when you had low levels within the infiltrate of these markers, then you're actually more likely to have clinically evident. So in clinically evident ones, these levels are low. And then this is sort of an interesting one. The three, I apologize for this being so small here, but the axis labels here on the left of this are never had cardiac allograft rejection. And this is for the next 2 years after the index biopsy. This is for, they did have one within greater than 6 months. And then future cardiac allograft rejection in the nearer term, 3 to 6 weeks later. And so what we see here is a gradient, right? In the people who never reject, they actually tend to, in their infiltrates, to have higher levels of these anti-inflammatory things. So it's a phenotype that predicts a low level of future rejection in the small numbers we have here. That those who had a future one but distant, they had kind of an intermediate one, but what's really interesting is people who were going to reject in the next 3 to 6 weeks had vanishingly low levels of the anti-inflammatory markers, regardless of their grade. And so we are getting some, this would be useful, right? If we had people, if their biopsy was negative, but we had a clue that they're at higher risk because they have very few anti-inflammatory markers in the cells that are infiltrating their myocardium, maybe we ought to intensify their immunosuppression selectively. Again, small numbers, we can't really go take this to the bank yet, but it's tantalizing. And so to summarize this, the molecular distinctions among cells comprising allograft inflammatory infiltrates provide new insights into the dynamics of allograft rejection, novel diagnostic information about allograft health, but I think especially the new insights about what's going on under the surface is really valuable. And that specifically the reduced proportions of cells expressing PD-L1, a checkpoint molecule, and FOXP3 are associated with clinical evidence of serious allograft rejection, even when conventional histologic analysis provides falsely reassuring negativity. And then the proportions are dynamic. And so what I didn't show is that when you look at the same person, they can change over time. And so this is like everything in the immune response, it's dynamic, it's changing. And so there's still some place for doing serial biopsies. You can't just do one at a given point in time and say, well, I know this person's future forever. Not so lucky, but nevertheless, they do give some prognostic value moving forward. And I want to finish up with the last application talking about chronic rejection. One manifestation of low-level inflammatory responses is cardiac allograft vasculopathy. It's an indolent immune-mediated vascular injury. It's actually the leading cause of allograft loss after the first year. So it's acute cellular rejection that we have, or antibody-mediated rejection that we have more trouble with in the first year. But thereafter, the rates of that are much lower, even though we tend to peel back our degree of immunosuppression. And yet, chronic problems like vasculopathy emerge. It's felt to have its origins and its risk factors in a combination of both traditional risk factors, lipids and smoking and such, and other factors that are more particular to transplant medicine. Some have, there's some signals that donor risk factors can carry over once it's in the recipient host, or that even CMV disease and things like that can affect things. Very important to emphasize, it's a different disease than garden variety atherosclerosis, right? It's not lipid-laden plaque for the most part. More of it is a proliferative arteriopathy where there's an extensive neointima formation, and it tends to be much more diffuse than the focal lesions we're used to seeing with epicardial coronary artery disease. And it's usually diagnosed with coronary angiography at different centers. They use non-invasive screening to help select who gets angiography because they're worried about people's renal function and other complications. Treatments are available, but they're typically implemented late. We don't, most commonly, we use things like rapamycin, but sirolimus has its own downsides and we don't want to use it in everybody. And so when people start having evidence of allograft arteriopathy, we often switch them to a sirolimus, including regimen, but again, it has some downsides. Now, we're not the first work in this field, right? There's a nice paper by Lupi from France that identified 6 risk factors that stratify heart transplant patients into low-risk subgroups for later graft vasculopathy with good sensitivity, but unfortunately, that had a very high false positive rate. So it would tell you who might be suitable for a rapamycin-based regimen, but on the other hand, it would have you treating an awful lot of people with that because its specificity was not good. And some of the factors are shown here, as I mentioned, based on donor sex, age, tobacco use, and recipient LDL or donor-specific antibodies, prior cellular rejection. It's interesting that the donor's tobacco use has more to do with it than the recipient's tobacco use. But most of our recipients don't use tobacco, so that's we don't see much of that. So the hypotheses we're testing here is computer image analysis can uncover novel morphologic biomarkers that might predict CAV, because that hasn't been, we've never looked to the biopsy to teach us about the vasculopathy risk. But if it's a diffuse disease that might also involve the microvascular components of the biopsy, maybe we should be looking there, and there are opportunities. And then integration with the clinical risk factors might give us even more horsepower, because the Lupi work is relevant, and we can do the same thing in our cohort and look at clinical risk factors. We shouldn't throw them out the window. They might be independent and orthogonal, and together add even more value. And so the experimental approach we took here is we took paired slides from people that had no CAV, because we have, again, this retrospective cohort design that allows us to look back and know who went 6 years without having any evidence of CAV based on their non-invasive testing or their coronary angiography. And which people, on the other hand, within that 6-year period or 5-year period did develop moderate or severe cardiac allograft vasculopathy, CAV. And so that when we're looking at their 12-month biopsy, we're looking at a precursor to their later development. So this was the design of the retrospective cohort study. In this case, we used 2 different stains. One is CD31, which is to highlight vascular structures, right, and endothelial cells and perivascular structures, and Movet's pentachrome, which is particularly good at distinguishing different parts of the extracellular matrix, particularly the collagenous and non-collagenous components of the extracellular matrix. And so these are what these 2 things look like. I'm not going to go into too much technical detail, but the Movet's ones are very pretty. They have 5 different chromes, and they end up looking like this after image processing. And so the workflow here is, again, we took a decent number of transplant patients from 2007 to 2020. Now, some of we're going to have to throw out from 2020 because they don't have 6 years of follow-up, right? So when we have N of 444 that did not meet the definitions for no CAV and pre-CAV. This wasn't some censoring of the data because they didn't work well. It was actually censoring because they didn't have enough follow-up time, or the patient, either because the patient died in less than 6 years, or it wasn't done 6 years before we were doing this analysis, or they transferred their care. But pretty much we took everybody in this interval that had enough follow-up. And then we compared the no CAV patients from the pre-CAV patients, as I just defined them, based on at 6 years, had they manifested or not. We also took a few archival biopsies of people who had a definite arteriopathy, and we used that to help train the algorithm and for comparison. So when this says DC biopsies here, those are disease control biopsies, right? So part of the training was to include some of these and say, this is what real vasculopathy case looks like. And then the other two we just defined based on their clinical trajectories. And again, what we developed from this is a clinical CAV predictive model, very much similar to what Loopy did. What variables in our cohort were predictive of later development of vasculopathy, and a histo-CAV predictive model is what things that you might see on the 1-year biopsy were predictive of later vasculopathy. And then we integrated the two. So that's the design of this one. And just to, again, not go into detail about the workflow, but there are things you can see, again, what's distinguished here from the MOVAT's pentachrome, there's a no CAV slide and a pre-CAV or disease control slide. And what you can see is the two features that we found most useful were a change in the collagenous portion of the interstitial stroma. You can imagine microvascular disease causing some myocyte loss and replacement fibrosis with collagen producing a pattern like this. But if you can see that at the tissue level, but not necessarily at coronary arteriopathy level, but the pathologist might be seeing this all the time and not comment on it because it's not part of the ISHLT grading scheme, and we never ask them to pay attention to microvascular impact on the myocardium. So again, when you're taking a fresh look at this, you see things that, that might easily be connected to vasculopathy, but we overlooked forever. And then you can also see other interstitial stromal proliferation, the non-collagenous. It's one of the advantages of the MOVAT's pentachrome. And of course, when you use a CD1 staining, you can get a variety of different features from whether how much endothelial cell thickening there is. Sometimes we talk about this as endotheliitis, cellularity within the vascular objects, cellularity in the vascular spaces, perivascular spaces, and overall vascular density. In this case, is going the other way, right? If you see a rarefied capillary network, that's a sign that, wow, we've had some dropout, and that's not good. And so these are all features that the CD1 staining was trained, we trained the algorithm to pick up. And to then cut to the performance, we found that our clinical CAV prediction model, its accuracy was about 66%, which is actually pretty similar to Loopy's, and the features that ended up independently coming out, 5 out of the 6 overlapped. And so we found, as Loopy did, that clinically known variables can be used to help stratify our patients into higher or lower risk, but it's not awesome. It's just, statistically significant, but not terrific. The histologic CAV prediction, based on the kinds of features I showed in the previous slide, the changes in the perivascular features brought out by CD31 staining, or in the extracellular matrix features brought out by the pentachrome stain, that was better. Its accuracy was more like 82%. And when you combine the two, as expected, because they're different flavors of data, we got even higher prediction value. And the area under the ROC curve, right? If you take a random positive case and a random negative case, and what's the likelihood that it'll pick out the positive case? It's 93%. So this starts to be a number that maybe you would take people like this who have at 1 year and start thinking about putting them on some additional therapy, whether it's rapamycin or vitamin C or some other approach. And so I think this starts getting more interesting in terms of being actionable. So to summarize this last part, morphologic biomarkers are superior to clinical risk factors for predicting CAV, and integration of clinical and morphologic risk factors is superior to either alone. These results suggest that morphologic details contained within regularly obtained, these are even centers that lower the number of biopsies, they still perform one at 1 year. That's not rare. They have potential to enhance our precision and personalization of treatment to patients with heart transplantation. And let me just finish with some more general comments about the whole 3 applications that I presented here. One is that computer-assisted analysis of routinely obtained endomyocardial biopsies has significant potential to address unmet needs that are relevant to cardiac transplant medicine, and that these tissue and EMR archives that we have and that we just most of the time leave alone are really valuable to doing fairly efficient retrospective cohort studies. So I'm going to represent my acknowledgement slide, and you'll see those 3 papers are in 3 consecutive years, and they're very different topics, but they're pretty efficient to generate. So this is a gold mine. The case of rejection grading, shortcomings with the longstanding ISHLT grading standard constrains the assessment and implementation of more promising new techniques. And that's not just our new technique with the digital pathology. It's also, donor-derived cell-free DNA and immune profiling of circulating lymphocytes. So these are 2 new technologies that are really promising for less invasive detection of rejection, much less invasive, and yet they're still going up against the same crappy reference standard, and their ability to prove themselves superior is constrained by the shortcomings of that reference standard. So again, I want that to be a general message that people come away with. And that characterization of cells comprising the infiltrate teach us about the dynamics of allograft rejection and the underlying biology and the interplay between pro and anti-inflammatory. One of the interesting things that we saw in the initial cohort, and that we see again in this, I told you we kind of tripled or quadrupled the number of cases, is when you look at a healthy myocardium, like from an unused donor heart, it's got PDL1 evenly distributed throughout. It's almost like there's a cop on every corner, keeping the peace. And a quiet myocardium has a certain number of anti-inflammatory mediators present in it. It's not leukocyte free. It has a particular subset of leukocytes that are mostly keeping the peace. And I think that's new biology. I think it's really interesting. And we have opportunities to interrogate that in new ways. And detection of early microvascular changes that predict later significant allograft arteriopathy could provide opportunities for disease-modifying interventions, as I mentioned. One little thing on future directions. Of course, we're going to do ongoing studies to compare with some of these other new techniques like donor-derived cell-free DNA and immune profiling, right? We'll be mindful that the grading from the pathologist may not be the best reference standard. We'll use our comparative effectiveness things and not fall into the trap of bringing down the new test based on the weaknesses of the old test. We'll do more studies. We need a validation, external validation, especially for the allograft arteriopathy studies. And beyond transplant, we wonder, we get myocardium from people with sarcoid, from other situations, from donors we're thinking about using for transplant. And there may be a bunch of other applications of some of the same methodologies. And once again, I'm going to show this slide. These are the individuals who did all the heavy lifting. And again, as I want to highlight, these papers have come out pretty quickly because there's great efficiency in these retrospective cohort designs. So don't fail to use what you have on hand. Thank you for your attention.
Thank you so much for a wonderful talk. We can take some questions. I'll run over here to Al first.
Great talk. We've been looking at PET imaging of flow reserve as a predictor of allograft rejection, and showed that sort of the number of rejections, episodes of rejection, correlate with an impairment in flow reserve. But perhaps more interesting and is targeted molecular imaging. So we've been looking at radiolabel probes to look at the alpha-v beta-3 integrin, that could look at angiogenesis. There are probes that can look at specific inflammatory markers, and your histologic data could drive sort of, what are the PET or SPECT probes to do imaging. One of the pitfalls of biopsies, of course, is it's sort of random sampling, where 3D imaging would provide you a comprehensive assessment of the whole heart and so the degree of inflammation or fibrosis or changes in the matrix.
I think that's absolutely true. I think also the head-to-head comparison gives you an opportunity to find out whether the sampling error is a big problem, right? If it's a diffuse microvascular disease, maybe in contrast to allograft rejection, which is typically more focal when you just on the face of it, maybe here we'll get away with more sampling, and we'll get a accurate representation of more diffuse processes. But that's a testable hypothesis, but only if you do both in the same people. So we'd be happy in the cases you've been doing PET in, we'd be happy to apply the algorithm. I'm sure they're going to have antecedent slides that were done in the phase when these people were getting biopsied, and we can see whether we see the precursors. So we'd love to collaborate on that.
Very nice talk. And you mentioned actually in your summary slide, but have you ever compared the profiling of immune cells in the blood with your specimen?
So
and also just the markers such as TNF and IL-10 and those markers.
Yes. So the answer is that's why we're doing a prospective study, and that's what the grant is funding. Aim 3 of the grant is all with prospective accrual. And although it's been slowed down a little bit by COVID, it's actually humming now. We're getting new transplants all the time and new people included in the prospective cohort because we have banked tissue samples in paraffin, but we don't have banked blood samples. So for techniques that weren't around, like cell-free donor-derived DNA or immune phenotyping of the circulating lymphocytes or mononuclear cells, we don't have samples to interrogate. So we have, but they're important questions. And especially when you're trying to find non-invasive biomarkers or less invasive biomarkers. So that's what the prospective studies are for.
Jeff Bender had a question maybe on the chat. Jeff, you want to unmute yourself and ask it?
Yeah, Ken, this is Jeff Bender. Sorry to not be there in person. That was an outstanding talk and wonderful work. I knew Margaret Billingham back in the day at Stanford, and this field has evolved very slowly. And I think the slope of the change in the field is rising dramatically with your work. So congratulations on that. I have a question. I think that your multiplex immune cell phenotyping is very cool and very smart. I have a little bit of a question about the FOXP3 positivity. And you describe that as anti-inflammatory, and it is, and it can be, but those cells, those regulatory T cells, as you know, can be allospecific regulatory T cells. And it sort of enters the sphere of what has been the holy grail and unachievable, which is transplant tolerance. So I wonder whether your plan is to look at the presence of those in your multiplexing and the absence of chronic allograft vasculopathy down the road, because maybe, it's been debated, as you know, for many years, whether the number of acute rejection episodes correlates with the eventual existence of CAV. And that may not be the case, but the opposite of that is the presence of regulatory T cells could predict the absence of CAV. So I wonder if your plan is to try to make that correlation and to think of why some recipients might be relatively tolerant to the donor.
So I think the general comment is, of course, I totally agree. It's brilliant. And the opportunities at intersecting the techniques that I highlighted here, whether it's the spatial distribution insights that we got in the first part when we're looking at rejection grading, and then why can't the distribution of the immune phenotyping subsets teach us about something, right? So it's likelihood that will both intersect parts 1 and 2, and as you suggested, parts 2 and 3, right? The multiplexed immunophenotyping with the vasculopathy later on. So I think, although I presented them as individual approaches, there's no reason why they can't be intersected, and it would shock me if we didn't learn some new things from those intersections. But we've been limited so far in our applications, but they're not hard to do, and we will, and hopefully others will too.
Good, thank you.
Ken, fantastic talk. It's really wonderful to learn from you over these many years we've intersected. So my question relates to the methodology of using retrospective cohort analyses, and I'm a huge fan. We did a fair bit of this work, which was, as you suggested, can really push teams forward, in imaging space. And then hopefully our group here is looking at that in heart failure and other places. But the challenge, and I'm curious how you address this in your own work, the challenge, of course, is that you're assuming we have to make assumptions that the cohorts are similar to the current state. And, with all the changes in transplant, populations of late, particularly, do you have any concerns about, and how would have you handled, or would you handle that methodological constraint?
As I highlighted, the grant includes an AIM-3. That's a prospective study that's been going on, for the past 2.5 years. And it's essential, right? Because you do have to validate things in a modern, not only in a separate cohort, but in a modern cohort. And in addition, you have assayable material that you can get prospectively that we can't get retrospectively. So I think there's sort of several, and so nothing's going to change clinical practice unless we validate it anyway. So between the need for validation, the need to do it in a modern cohort, and the need for to include comparators and biosamples that can only be gotten out, all favor. You have to do the heavy lifting of the prospective study. But what I view the retrospective cohort studies is how this is a place worth digging into, because we have signals that are pretty compelling as retrospective studies can be. And so I agree with you entirely, but there's value, but it's necessary but not sufficient.
And one maybe follow-up question methodologically. So, completely agree. It's a crappy standard, but it's the one we've lived with. But the retrospective cohort studies and this work that you've done actually provides an opportunity to actually skip the standard, so to speak, and just say, well, all that matters to patients is, in my opinion, is whether they're alive or dead, and if they feel better or have avoided complications that impact quality of life. So have you actually taken your cachet mechanism and applied it independent of the grading to an outcome?
Yes, but that's still sort of emerging. And I do think it will have value added for the predictive value, but not nearly as much as you get with the immune phenotyping. It looks like there's a much bigger signal of impact in distinguishing among the immune phenotypes that are present in an infiltrate. The other thing I want to mention is the possibility for pathologists to get updated training. I mean, the pathologist isn't the lesion, right? It's the grading standard that's the lesion. And I think we expected too little of it. And so there are, if we gave the pathologists maybe 1 or 2 stains instead of just H&E, and we gave them some insight from what the machine learning is interrogating, look, we all read ECGs, right? And we have the preliminary read, and do we take it to the bank and trust it completely and just put our signature on it? No. Do we ignore it completely? I don't. I actually look and, and so it's a decision aid. And I think that's what we should view this as. It's a decision aid, and neither of the extremes makes the most sense. Neither ignoring the human being nor ignoring the decision aid makes it's the two together.
Spell check function.
Yeah.
And the hour's getting late. Maybe you can ask in person if you have time, Aria. I want to thank everyone for coming, and thank Dr. Margulies so much for sharing this beautiful work and this exciting approach with us.
Thank you. Thanks for having me.